TopMedTalk.
Nick Majerison here. Welcome to TopMedTalk. And on today's TopMedTalk, we're going to have a piece taken from the 20th Current Controversies in Anaesthesia and Perioperative Medicine Conference, held in Dingle by EBPOM. Don't forget, of course, you want more details on this podcast. Full show notes are available on TopMedTalk.com. Have a listen.
So finally, to round off these three sessions, it's a pleasure to welcome a friend, colleague and mentor from Southampton, Mike Grocott, who amongst other roles is the chair of the Perioperative Medicine Group at the Royal College of Anaesthetists, which in effect means he's entirely responsible for delivering POM within the UK. So no pressure. Mike has been known to say, quote, I'm all over it like a rash, so that's fine. Mike, welcome.
Thank you. So Dingle, day 3, after lunch, third talk of the immediate post-lunch session. I will endeavour to infuse some energy. I'm going to spend about half this talk reflecting on some personal views, so you can't blame the college for those, and then half of the talk reflecting or talking about what the directions that the college is going in relation to perioperative medicine. What do you see? Glass half full, glass half empty. So we all have our different perspectives. Mine typically is glass half full. There's nothing new under the sun. This is a nod to Ross. Get off your phone. Always impressive to look back at what he was doing when I was still at medical school. Sorry. But actually, if we look through the anaesthetic literature, even way back in the 1940s and 1950s, although they didn't call it perioperative medicine, there were practitioners focusing on the role of the anaesthetist outside the anaesthetic room and the operating theatre and how they could help their patients in that way. And it doesn't feel so brave writing this title. So so I wrote this with Rupert Pearce. We both graduated in 2005. We wrote this in 2011. It was published in 2012. It felt like quite a brave thing to say at the time. I don't think it is at all now, but hence we had a bit of anguish about whether we should put a question mark on the end. And we opened it with a quote. It's a JFK quote a couple of days before he did his famous Ich bin ein Berliner speech, but a quote about the inevitability of change, which I think is important, and sometimes it's easy to not see the extraordinary changes that have happened over the last 10, 20, 30, 50 years, and the rate of change will be at least as fast looking forward. And the other quote, which I've started using more recently, is this one, which is commonly attributed to Charles Darwin. It wasn't actually his, it was a sociology professor, paraphrasing what he thought Darwin had said. But this notion that you don't have to be really smart, but you do have to be adaptable to change, and there's probably a message there for us. So a little bit of a warning, if you're feeling queasy after last night, I would look away for the next few slides, because there's some information that could be considered threatening, but equally within every threat is a potential opportunity. I couldn't resist the next slide. It's got absolutely nothing to do with the talk, but I love the cover of Private Eye this week. Whatever your views about Brexit, there will undoubtedly be opportunities whichever way we go. We've seen this before, or variant of it. So the NHS is the 5th largest employer in the world. 2/3 of the NHS budget is payroll, and the most expensive people in the NHS are the consultants. So all of us either who work in the UK either are consultants or will be consultants at some stage. And if you were managing the NHS, that's the bit of the bill that stands out most as the bit that you certainly wouldn't want to be increasing a lot, and you might actually quite like to reduce a lot. You either do that by reducing number or reducing cost. This is a map of the United States showing the states that now have essentially parity, not necessarily practical parity, but legal parity between non-physician providers of anaesthesia and physician providers of anaesthesia, i.e. the non-doctors are legally entitled to do what the doctors are in terms of anaesthesia provision. I thought Anna gave a great presentation yesterday about the potential role of physician's assistants and the various other labels there are. I think this is coming, and I honestly think we should welcome it. We may want to be part of managing it. We may want to be part of managing the rate of it. But I think if we stick exclusively with our practitioner role, and particularly if we stick with the practitioner role within the operating theatre, there are risks. And there are risks in part because of this, which is the fancy tech. I won't go through the detail of all the different elements, but probably best to highlight a paper in Anaesthesia and Analgesia in 2016. It was a study of closed-loop anaesthesia provision, including the whole anaesthetic, not just the anaesthetic agents, but the fluids and the oxygen and everything else. So the entire thing is closed-loop. It was a small 20-patient feasibility study, and feasibility was the patient gets to the end of surgery without the attending anaesthetist touching anything. 16 out of 20 patients got through cardiac surgery on that criteria. So you can do a lot of the elements, not when it goes wrong. We're not by any means completely replaceable, but a lot of what we do is potentially replaceable by tech and by other folk, and therefore thinking about our role is going to be very important. And thinking more broadly, we've also seen this earlier on, so this is the Marmot determinants of health. And it's kind of sobering that the healthcare bit, so we feel, I would imagine all of us, very proud of our role in contributing to health, and that's a worthy goal. But the healthcare bit's a relatively small slice of the cake. So if you're a government or a policymaker attributing budget, you might look at this and rationally think, well, maybe I shouldn't put too much money in the 20% slot. I should be putting money in the 40% shot slot and worrying about socioeconomic factors or worrying about the built environment, for example. Which brings me on to the triple aim. I think it's been alluded to by a couple of speakers already in the last couple of days. So this notion of better health for populations and individuals at the same time as lowering cost. And we know we can't have a relentless increase in costs. So population health, Sol's been talking about, healthcare, which most of us are involved in daily, and the recognition that value is our problem as well. It's not just the manager's problem. So the triple aim was implicit to the 5-year forward view. The 5-year forward view being basically the roadmap for the NHS in England from 2015. It was actually explicit in the sort of halfway update on the 5-year forward view. And these were the key priorities. And these are priorities that play very strongly for perioperative medicine. So prevention and public health, we've heard a lot about prehabilitation, about the potential benefits for prehabilitation in terms of long-term behavioural change, shared decision-making, that's all about patient control of their own care, breaking down barriers between primary and secondary care. A lot of the work before admission and after admission is mission-critical for perioperative care, and the issues around health and social care. And I think the key things that will be important for us are the integration messages. So the integration of health and social care, even more pressingly the integration of primary and secondary care. Because I don't know about your practice, but I think in general we are desperately bad at communicating with our primary care partners. And we also cannot see them as the solution. I think from the people I know who are in the primary care space, their world is harder than ours, however hard we think ours is. And the other thing is the evolution of funding models. So how we pay for healthcare is moving. I think we probably start roughly on the middle of this line, but in the UK. But it's moving from a fee for service, which inevitably is an incentive that drives activity. If someone pays you for doing something, you're quite likely to do a bit more of it. To a capitation approach, which incentivises a completely different approach to activity. Because actually you have a budget now to look after the health of a population. You may not want to do particular types of surgery. You may not want to employ particular types of specialists. That was all a little bit negative. I think those are drivers for change. They may be positive or negative. The biggest driver for me for perioperative care is that a lot of healthcare for the last 70 years since the establishment of the NHS, to a lesser and lesser degree, but a lot of it has been based around the doctors. And actually, I think most of us would agree it probably should be based around the patients. And certainly most of us, from a patient perspective, would like it to be based around us as patients. And I think perioperative medicine is superb from that perspective. But I would point out that when you ask patients about care, so this is a national survey takes place every year in the UK, the things they expect from health and care, as if you put your own patient hat on, as we do really, is a consumer experience. They want people to be nice to them. They want it to be readily available. They want to be able to, drop into the local chemist and get a lot of their healthcare needs rather than waiting 2 weeks for a GP appointment. And we need to be alert to those drivers. So I think perioperative medicine is about evolution of identity, and that's been happening in the UK. I think the first sort of institutional body to shift was the NHR specialty group, which became Anaesthesia, Perioperative Medicine and Pain in 2011. The college flagged up their perioperative medicine strategy in 2014, And I would imagine most of you have now seen, the Association and Anaesthesia, the journal, have rebranded just a couple of months ago and now have perioperative medicine in their strapline. And I think there's an evolution of identity. Most of us see ourselves as doctors. We've earned those medical degrees. We've then become specialists. We are anaesthetists, and we have a clear role in a hospital, and that's our identity. But actually, that may not be what's needed to look after the care of patients who are having surgery before, during, and after surgery. And service delivery, which is generally our principal function, may not what we are principally needed for looking forward. The leadership and development of services may actually be what the medical profession increasingly is called on to do. I'm going to change tack a little bit. There has been a grassroots explosion in perioperative medicine in the UK over the last 10, 15, 20 years, and I, with due deference to my two other speakers, I would argue we are leading the world, and I think that arguably the college is leading the world. Them cursed Aussies are pretty close behind, and I think Sol would accept, and we spend a lot of time together in the States, probably because of the financial drivers, they're substantially further behind, as are most of the rest of the world. I've flagged up a bunch of centres that are doing great work in different areas. I've put the question marks there because I'm bound to have forgotten some, and I don't mean to offend. I'm just highlighting places where I know there's really good work being done. And I think the college has done the right thing, taking the initiative with the perioperative medicine strategy in 2014. I think it's very visionary of JP Mandasau at that time. This, of course, was led until very recently and rightly by Monty. And the clear notion that it was patient-centred, it was multidisciplinary, and it was integrated. I think that the early steps have been appropriately cautious, and they've been largely anaesthetic. So we've had a task and finish group that set up some structures. There's now a leadership group. We've refined our curriculum, which has now gone to the GMC. So if you are, similar to in Australia, if you're an anaesthetist with a CCT after 2016, you are qualified in perioperative medicine as well. And we've got a multidisciplinary advisory board. And there have been a number of, so we've got clinical leads, we've got a clinical fellow who spoke at this meeting, Anne-Marie. We've continued engagement with stakeholders, we've had regional events. There have been some great college-based training events on particular issues, notably anaemia and shared decision-making. But we've largely kept it in-house. And in truth, the leadership group, the vast majority are anaesthetic individuals. And I think that's going to have to change. We've also focused on some pre-habilitation-based initiatives, but in the interest of time, I'll skip over those. In general, the membership have been very supportive of that. So the first membership survey, perioperative medicine, was rated as important by well over 2/3, that's 2015, and the most recent membership survey, as in what are the core roles of the organisation, championing perioperative medicine, 44%. Thought that was a core role of the college, and that's a positive step. So I think the college will move further forward on this. The initiative which passed college trustees about 2 weeks ago now, the document started with this statement, which I hope is the sort of statement that would meet with everybody's approval, that patients' best interests should be at the centre of it, that perioperative medicine should be woven throughout college activity, and that we should be leading nationally and possibly internationally on standard setting and training, professional education, quality improvement, all the elements, research, policy, that are important to perioperative medicine. I'm going to flag these. It says editorial by Maxine Cannison, Monty and Zeev Kane, bewailing sort of celebrating the fact that everybody was into perioperative medicine, but that the labels were rather complicated. And there was a response by, 3 anaesthetists, a response by 3 surgeons, very gently prompting that we probably should be a bit more externally looking and engaging with our surgical colleagues. And I think that is where we will be going in the next few years. And there will be established at the college a multidisciplinary, i.e. multi-specialty centre for perioperative care within about the next 9 months. So the ambition is to launch this for the Anaesthesia 2019 meeting in May. And so it's an important message that the college should be leading this. It should be based at the college, but it should be about multiple specialties working together. So on whatever the governance structure is, on the board will be representatives from the College of Surgeons, the Royal College of Nursing, the College of Physicians, the geriatricians, etc., the Royal College of General Practitioners. We thought very carefully about the name centre, and the principal reason was that it wasn't a faculty. And as my father said to me, and in fact his father said to him when I told him I was getting engaged, he said, "You do understand that's a natural progression towards marriage." And unfortunately, the creation of faculties seems to be a natural progression towards independence. So the Faculty of Intensive Care Medicine, which I have been a huge fan of, I remain a huge fan of, but I always thought, great, we've got a faculty. Actually, it's slowly splitting anaesthesia and critical care, and I think Ross might reflect that in Australia, who are 20 years ahead of us in that journey, that may not have been a great success in the long run. Maybe keeping those specialties together might have been a better thing. And I think removing perioperative medicine from anaesthesia would be deeply destructive and the wrong thing to do. And Centre for Perioperative Care, not medicine, because this is a multidisciplinary game, and not all those involved are necessarily physicians. So, Centre for Perioperative Care, coordinating initiatives across the health and social care landscape, working with stakeholders I've talked about, directly engaging with providers such as NHS England, working regionally in a way that the college sometimes doesn't do brilliantly, but is trying hard to improve on, and working globally through the Global Health Strategy. It will do or guide the college in doing all the things that you might expect around standards and guidelines, training and credentialing. So anaesthetists are already credentialed as of the recent past in perioperative medicine, but there are others who wish to be credentialed in that way, and we need to look at that. Workforce, physician and non-physician providers, quality improvement research, and importantly, policy. There are big issues such as, for example, the 62-day wait. Should we be modifying a 62-day wait for surgery if we can do things that can actually improve patient outcomes? That's an important policy issue. So, moving forward, we're merging the leadership group into a centre. We're bringing on board many more outside non-anaesthesia stakeholders. We will use this to inform the structures we've already had that are effective within the college, such as AXA and GPAS, so departmental accreditation, standardised guidelines. And it will also, and this is my last but one slide, it will also be the home of the newly forming International Board of Perioperative Medicine. So one of the reasons a bunch of us are going to San Francisco is because of something which has been for about 3 years the International Perioperative Curriculum Group, which has been all about curriculum harmonisation between the States, Australia, the UK and other countries, is now morphing into a formal international board of perioperative medicine. And there are other international initiatives, including the Perioperative Quality Initiative, which we can talk about in the questions if helpful. My summary, perioperative medicine, I think we are leading the world in the UK. I think we should be proud of that. I think it should be all about the patient. It should be multidisciplinary and collaborative, but it should certainly be led by anaesthesia. Thank you.
Nick Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com, and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. EBPOM.org is their website. That's EBPOM.org. And if you go to EBPOM.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's EBPOM.org/meetings.